On behalf of the ItOSS COVID-19 in Pregnancy team, I would like to thank you for the invitation to share some of the results we have so far. My name is Hilde Engjom. I'm a Norwegian obstetrician gynecologist, and I currently work at the Norwegian Institute of Public Health in projects related to severe maternal morbidity and mortality, and also to COVID and pregnancy surveillance in Norway. As you've heard from previous presentations, currently there's 12 European countries active in the ItOSS collaboration, covering a source population of around 2 million births per year. And the previous studies on maternal deaths and severe morbidity, including the work on aligning definitions and exploring differences in care, was crucial to enable rapid establishment of surveillance of SARS-CoV-2 infection in pregnancy as the pandemic hit. And I'll start with a brief overview of the pandemic in Europe. Following China, Europe was the epicenter of the pandemic from March 2020 and onwards. And the governmental responses have been described using the Oxford Stringency Index, and Italy was first to reach a threshold of the index of more than 50 on February 24th in 2020, followed by Netherlands and Denmark, Belgium and Norway, France, Finland and Iceland, and then later the United Kingdom towards the end of March, and Sweden on March 26th. During the period of 2020, the wild type or Wuhan variant of the virus was dominant in all countries in Europe. And it's also important to keep in mind that vaccination rollout started at the earliest in January 2021, and pregnant women were first included in April to May 2021. So the period I'm going to describe for you now is during the first 10 months of the pandemic, from March to December 2020. During that time, approximately 1.7 million women gave birth in the participating countries. We registered pregnant women admitted to hospitals, and all countries used case report forms modified from the ItOSS form. And all countries had systems in place to ascertain complete reporting, but the systems varied. So we included pregnant women admitted to a hospital with a SARS-CoV-2 infection, defined by a positive PCR test within 7 days before admission, during admission, and up to 2 days after giving birth. Most countries had national surveillance. In France, the participating hospitals and regions covered approximately 60% of the women giving birth, and in Sweden, approximately 30%. The primary aim was to describe the incidence of admission, the severity of COVID-19 disease in pregnant women, and also the medical treatment given to pregnant women. And as you can see in this flowchart, among the 1.7 million women giving birth, 8,747 were admitted to hospital with a positive SARS-CoV-2 PCR test, according to the definition. We further divided this group by the cause of admission or symptoms. So either women admitted due to COVID-19 or recorded to be symptomatic if cause of admission was not known, or women admitted for other healthcare or asymptomatic. And as you see in the second level in the flowchart, approximately a quarter of the women with a positive PCR test were admitted due to COVID or symptomatic. The other group would be impacted very much by screening policies for women coming to hospital for labor or coming to hospital for other obstetric emergencies or obstetric-related healthcare. So in the following, I will focus on those admitted due to COVID or symptomatic. And as this plot shows the incidence of hospital admission due to COVID or with symptoms per 1,000 maternities. And you can see there's quite striking heterogeneity between the Nordic countries on the lower level, with incidence from no admissions in Iceland to 0.2 and 0.4 per 1,000 in Norway and Finland, and the highest incidence in France, the UK, and the Swedish regions. Further, we did see a considerable variation over time in the different countries. This shows hospital admissions due to COVID or with symptoms per 1,000 maternities by month of the positive PCR test. And as you can see, the lowest level is in the 4 Nordic countries and the highest level in France, UK, and Swedish regions. Further, we defined moderate to severe COVID-19 disease as maternal death, intensive care unit admission due to COVID infection, and a need for respiratory support with either oxygen, high-flow nasal cannula, continuous positive airway pressure mask, mechanical ventilation, or extracorporeal membrane oxygenation. And in the countries where complete information about respiratory support was available, that is for 2,227 of the women admitted due to COVID, we see that 822 needed respiratory support or higher level of care, and that is equal to around 40% of the women admitted due to COVID or with symptoms. This table shows the severity outcomes by country. So as you can see, there were few deaths related to COVID-19 during the first 10 months of the pandemic. ICU admission ranged from 7.8 in Italy to 18% in France and 19% in the Swedish regions. And it did vary what kind of respiratory information we had available. So Belgium did not record oxygen supplementation, and in the Nordic countries, it was not possible to discriminate the CPAP from oxygen supplementation. So we've had to adapt the table according to the available information. We also did risk analysis to look at maternal risk factors for moderate to severe COVID-19 compared to those who were symptomatic but did not need respiratory support. And you see that the age 35 years or older, obesity, and migrant or minority background were risk factors in all countries, but keep in mind that for the very small data sets, low numbers will mean that the confidence interval is very wide. What is of more concern is the medical treatment given to women with moderate to severe COVID-19. This graph shows the proportion of women with moderate to severe disease who did receive antiviral treatment. There's a big variation across countries, and overall 1 in 7 women who needed respiratory support received antiviral treatment. Further, regarding corticosteroids, 1 in 6 women received treatment more than 2 doses indicated for fetal indications or with a stated maternal indication. And keep in mind that this also covers the 6 months after the publication of the first recovery study on steroids and COVID-19 disease. 1 out of 3 women with moderate to severe COVID-19 did receive thromboprophylaxis. And 1 in 2 women were delivered by cesarean section. But again, here all indications for cesarean section are included. So this can also be non-COVID indications. When it comes to perinatal outcomes, and severe outcomes like stillbirths, most countries didn't have any events. Among women admitted due to COVID or symptomatic, there were 23 stillbirths, but 56% of the stillbirths were recorded in the group of women with moderate to severe COVID-19 disease. So in summary, the risk of admission due to COVID varied across countries and over time, and it was lowest in the countries that implemented suppression public health interventions early in the pandemic. And this large variation between countries with comparable obstetric healthcare do indicate that the public health interventions aimed at reducing transmission also protected pregnant women from severe disease. And so we've so far concluded that public health policies played a more substantial role to prevent the risk of severe disease than previously acknowledged. We also found that few pregnant women with moderate to severe COVID-19 did receive COVID-19 specific medical treatment. Even for medicines where there was little or no concern for adverse fetal effects. And this also leads to very difficult entanglement of the effect of medical treatment on maternal and perinatal outcome, because even the most severe ill women didn't receive medical treatment. The strength of the ItOSS collaboration is that the population-based surveillance gives us denominator data and enables assessment of the incidence and also to address the health system and public health factors. Previous work on the aligned definitions aid comparability across the countries. There's a lower risk of selection bias, and we did have available clinical information, so there's a lower risk of misclassification bias and attribution of severe outcomes related to obstetric emergencies to viral infection that didn't have a substantial impact on the causal events. And we were able to include findings from small national data sets, which reduces the risk of publication bias. We did identify some substantial challenges, and that's also limitations of the work. So local regulations and few resources did definitely impact the timeliness of available data, and that is related both to case detection and consent and other requirements, and also to privacy regulations and reporting of small numbers. The workload for the clinicians who participated both in the surveillance and who did the reporting was substantial and obviously increased during different waves in the pandemic. And all countries had systems in place to ascertain complete reporting, but these were adapted to the national infrastructure and they were not completely uniform. So for the future, we think that robust and timely population-based surveillance is essential to assess incidence and to address the health system and public health factors. And this will require planning and investment. And we also need further efforts to remove the barrier to receive timely and effective treatment for pregnant women, and to ensure that prevention options like vaccines also are available for pregnant women. Some countries concluded their surveillance early in 2021, and thus during the Alpha wave. During the Delta wave in the autumn of 2021, the countries with ongoing surveillance were able to compile information about the pregnant women admitted to intensive care and to show that they were mostly unvaccinated. And at least in Norway, this was a great help in communicating to pregnant women about the importance or personal protection with vaccination. So I would like to acknowledge the contribution from the national ItOSS teams, and last but not least, reporting clinicians in all the countries who did make this work possible. Thank you very much.